We're good. I originally was not going to be presenting on spinal anatomy. Dr. Suzanne Theron, who's a genetic scientist and neurosurgeon at the VA, had some issues with travel with SFN and then a really busy clinical schedule right when she came back. And so I'll be doing the talk on spinal anatomy. So bear with me on this. It's been a little bit since I've gone through this. I have no disclosures to give. My background, I started my PhD in functional spinal cord MRI. That sort of those skills and expertise gave me a lot of opportunity to collaborate with people doing structural imaging. So I moved into structural spinal cord MRI, and then have grown from there and trying to help develop analysis techniques to improve and automate our spinal cord imaging analysis. But on there, I don't say I'm an anatomist, so that's not me. I've had spinal anatomy. I've done some gross anatomy. I was a TA a little bit, but it's been a little while since I've done this. So the goal here with this talk on spinal anatomy is to give those in the room who may not have that background some of this information, which will then be definitely useful for the other parts of the talk the next 3 days. So I'm going to cover spinal cord anatomy. Very briefly, spinal cord neurophysiology, then look at spinal anatomy, and touch briefly on degenerative pathologies. And there'll be some other additional talks, especially on the third day on Friday, that'll go into other conditions such as multiple sclerosis, traumatic spinal cord injury. But I'm going to focus on what I'm familiar with, which is degenerative pathology. So here's the spinal cord. And so it's the caudal extension of the brainstem. And as you come down, you can see from superior to inferior, you have some pairs of spinal nerve roots that are coming off, which are very important. As you get down into the lumbar spine, you start to have the cauda equina. So the spinal cord stops around T12-ish. And I'll be explaining what T12 is as well. But again, spinal cord, addition to sort of the superior inferior longitudinal organization, you also have a cervical enlargement. So this is on the top here. Let me just figure out how to use my pointers. There we go. Maybe I will use a mouse instead. Apologies. All right. There is a cervical enlargement up here, and also a lumbosacral enlargement down here. And those contain additional motor and sensory afferents that innervate your upper and lower limbs, respectively. The spinal curves, you have, if you look at sagittally along the spinal cord, you have in the cervical spine, which is your neck, you have the cervical lordosis. The thorax, which is the part of the spinal column where the rib cage attaches, you have a thoracic kyphosis. And then in the lumbar spine, you have a lumbar lordosis. And so why are those important? They're important for imaging in that we are commonly trying to limit the lordosis as much as possible, and I believe this will be talked about later, to try to have your cord as straight as possible so we can align our slices, our axial slices, as perpendicular to the cord as possible. And then similarly in the lumbar spine, when we're doing imaging, we commonly prop up their legs so that their hips are in flexion, which can also help flatten the lumbar lordosis. And then we position our field of views, which we can position obliquely so that we're trying to be perpendicular to the cord as much as possible. Some of the other anatomy that's important is the cardiovascular anatomy. So you have the heart, this giant pulsating sac of fluid, then also the ascending aorta. Those are large arteries that are going to your head, as well as your descending aorta and the other arteries that branch out. And these are large sources of noise within our imaging that we're trying to mitigate to be able to achieve the best quality imaging as possible. In addition to the heart, we also have the lungs. And these, instead of being large pumping cavity full of fluid, these are now full of air. And so you have very differences in sort of the tissue properties and the densities of those tissues. Yeah.
I left my belts here last night.
Oh, you got it. No, can you play them?
Yeah.
All right. All right.
Going to medication class, psychiatry 233.
All right, thank you. No worries. And it's also another tissue that we try to optimize our imaging to be able to have better signal. And one of the issues with these is a field inhomogeneity, and this will be discussed more in some techniques to be able to mitigate this with advanced shimming options. But they can distort and lead to signal artifacts within the spinal cord, which we want to mitigate. So spinal cord anatomy, again, it's a caudal extension of the brainstem. It's encased by this vertebral column. You have the spinal cord segments, pairs of spinal nerves, and as well as the cervical and lumbar enlargements. And then at large, left-right symmetry, we kind of assume exists in the spinal cord. If we look cross-sectionally, we have a central core of gray matter, which has dorsal horns, a dorsal horn, a ventral horn, intermediate horn or intermediate zone. We'll talk a little bit about the rexid lamina, as well as other individual nuclei within the gray matter. But the main thing is that it is highly organized, and there's important functional components to the spinal cord gray matter. Now, it's surrounded by a lot and several ascending and descending white matter tracts, which also have a specialized function, and it's all highly organized. Talking a little more into the gray matter, there's a couple ways to discuss the gray matter anatomy. One is to break it down into rexid lamina. And so you have these different lamina, which are based on their cytoarchitecture. So similar to your cortical layers in your brain, you can think of having similar layers within your spinal cord, with having in the dorsal horn being sensory components. At least we're sensory afferents from the body, first synapse in the central nervous system, and then in the ventral horns having these motor neurons, which then go out and innervate muscle, causing contraction. And in addition to the lamina, there's also nuclei that you can define within the cord. And some of these, like substantia gelatinosa, having a role in pain and pain modification. Dorsal nucleus here, intermediolateral nucleus. This is involved in sympathetics. So your sympathetic nervous system, those neurons are located in the thoracic spine. These are the preganglionic, I believe, where the cell bodies are for those neurons. And then I mentioned the motor neurons in the anterior corner of the cord. This is a cross section from the C7. So we're up in the neck, the cervical spine, and we can see the gray matter here in white histologically, surrounded by the white matter and the white matter tracts. Now, these are highly organized tracts with specific functions. I'm just going to point out three of them. One is the dorsal columns here, and this is the gracile fasciculus and the cuneate fasciculus. These are involved in fine touch, proprioception. Information is relayed along these. You have over here your spinal thalamic anterolateral system. This is for temperature, pain, crude touch. And then this is your cortical spinal tract here, lateral cortical spinal tract, which is your primary track for voluntary movements of the limbs. Okay. If we go to the next slide, this is across the thoracic spine. So this is at the T4 spinal cord segment. One thing you can visually note is that there's a lot less gray matter here, so a lot more white matter. We're not in the cervical enlargement, but we're now in the thoracic spine. You have a similar sort of organization of these white matter tracts, at least grossly kind of in the same area, but slight differences in sort of their size and their position. And then if we come down to the L4 spinal cord segment, again, you see a much larger area of gray matter in the center, as well as the surrounding tracts. And here you can actually see some of the tracts are gone. So we no longer have the cuneate fasciculus, which is more for the upper limb and the lower lumbar spine. We just have the gracile fasciculus, but overall their organization is kind of the same, but also changes. Well, how well can we distinguish the sensory and motor activity with MRI? And really, it depends on what kind of resolution that you're doing. Here's a high resolution, some sort of staining of the gray matter. But depending on what your resolution is, and this is a 2 millimeter resolution over. Sorry, this is actually 1 millimeter in plane resolution. This is 2 millimeter in plane resolution. Typically with our structural imaging, we're at a 0.8 millimeter in plane resolution. Definitely allows us to be able to identify what's cord, what's cerebral spinal fluid. Difficult maybe to know exactly what's white matter, what's gray matter. So we do the best that we can, trying to push for higher resolution imaging so we can better identify these structures, quantify them, and measure different activities. So what I like to do is be simple, is try to just break the cord down into different quadrants, at least the gray matter, where we have the right ventral, left ventral gray matter with motor functions, the right dorsal. I've got some other things on here. Sorry about that. Motor functions, right dorsal, left dorsal with sensory function. And then the white matter structures on the outside. And we'll be talking about the spinal cord toolbox and the availability of these atlas-based tools to be able to help us identify where approximately different tracts are located within someone's cord, and also tools there to identify gray matter versus white matter. So I want to describe sort of one of the functional units of the spinal cord, and that is the spinal cord segments. Superior inferiorly, every so often, you have a spinal nerve root that comes off. And this nerve root is a combination of the ventral rootlets and the dorsal rootlets, which then combine to form a spinal nerve. This bulge here is the dorsal root ganglion, which is the cell bodies for the primary afferents in the periphery. It's an important thing. I forgot to put any more discussion on in the talk, so just note it here that I did mention dorsal root ganglion. The name numbering of these spinal nerve roots is something important to get to understanding, because it's important in the analysis step to understand where you are in the cord. There's a few ways to look at it. You could use the vertebral landmark, so vertebrae, what those vertebrae are. Are you close to that? That means that's where you are in the cord. But we think it's more accurate, and there'll be discussion on this, to be able to look at where in the cord based on the spinal nerve roots. And so these start with the C1 spinal cord nerve root exiting above the first cervical vertebrae. You then label them correspondingly until you get down to the C7 vertebrae, where you have an extra one called C8, and it comes off below. And then from there on, the naming is done based on where what vertebrae it exits under. So you have the T1 spinal cord segment then exits under T1 here. And so good to have this understanding. If you look down here in the lumbosacral cord, you can then see that the cord stops around T12, L1, and then you get this called cauda-equina. And those are those nerve roots that then pass down and out of the vertebral levels farther below. These spinal cord segments give rise to this concept called dermatomes. And these are patches of skin that have been identified to be innervated by a specific spinal nerve root level. So for example, the back of your hand, your middle finger is typically C7 the C7 dermatome, because it's believed that the C7 nerve root is innervating those structures. That said, if you look back historically, there's a lot of variability in these dermatomal maps. In general, dermatomal maps are very helpful clinically to try to identify nerve root pathology, but there are some limitations in these maps. There's a variability between them. It's uncertain sometimes what neuroanatomy is being mapped. Is it the nerve root? Is it the dorsal root ganglion? Is it the ventral or dorsal rootlets? Or is it this concept of spinal cord segment? They always assume left-right symmetry. They always show very clear boundaries between these dermatomes, which are things that I don't believe are true, but it's the best that we are able to do right now. And then I really like this paper, but it kind of questions this idea of segmental organization. And is there really a functional unit of the spinal cord that's a segment, let's say? And it depends on how you identify. Do you identify this anatomically or you try to identify it functionally? But in this paper, these anatomists, not an area that I'm an expert in, but they actually teased apart all of the dorsal and ventral roots. And when you do this, you actually don't see segments, maybe perhaps, but you see more of a lattice or just a superior inferior gradient of the nerve roots and rootlets. Then I want to talk about myotomes. And in general, the body muscles are innervated segmentally, we believe, as well. But most muscles have are multi-segmentally innervated, where it's not a single nerve root that is supplying the sole efferent input to those muscles. And the motor neurons themselves are aligned in columns within the cord, and those columns span multiple spinal cord segment levels. And then also, it's just not sensory information. It's just not motor information. There's a lot of stuff going on in the cord. There's reflexes that we're well aware of. And there's a lot of processing. We don't fully, I think, understand it, at least in humans very well, or in a large scale sort of picture. But there's these interneuronal processing, and interneurons are inhibiting, facilitating, allowing for communication between different parts of the cord. And highly involved in walking, repetitive movements, pain modulation as well. Now, how am I doing on time? Pretty good. All right. Let's dive into a little bit on the vertebral column. So I'll give you an idea of the spinal cord. The vertebral column, so the spinal cord is encased in bone and ligaments. And the vertebral column gives support to the thorax, so it has something important in biomechanics, in motor function. You have your cervical, the neck, thoracic, your mid-back, your lumbar, which is your low back. You've already discussed this, the sagittal curves. In general, the healthy spine, you don't see curves coronally. Everybody has a little bit of coronal curve, but ideally, it's going to be straight down the middle. Very important for when you're positioning patients for scanning is you want to try to align them coronally so that their spines are as straight as possible. Not always possible to do because you can't see inside them until you take an image. Each region of the spine has kind of common characteristics of the vertebrae. So this is the cervical spine, the neck, thoracic, mid-back, lumbar, the low back. As you can see, as you go from top to bottom, the vertebrae get bigger because they're supporting more mass. There's a bunch of shapes, and we could go into what all these processes and different aspects of the anatomy. It's not necessarily that important for getting started on these things, but most of these are attachments for muscles and ligaments and allow movement. But letting you know, I want to talk about there's a couple atypical vertebrae that are good to mention. One is C1. So C1 is the atlas. It's the first vertebrae. It articulates with the skull. It is ring-shaped. And then the second vertebrae is the axis. And it has this odontoid process here. And it's kind of shaped like this. And the atlas sits on there and allows for rotation of your head. So most of the rotation of your head is at that atlantoaxial joint. It's important for various conditions. But why is it important for us? Oops, sorry, I'm skipping ahead. Second atypical vertebrae is the sacrum, and this is below the lumbar spine L5. Then you have the sacrum, which articulates with the pelvic girdle, and also another atypical vertebrae. So why are these important? They're important because they serve as landmarks for our imaging. And in particular, we really like to use C2 on the sagittal to start counting down where we want to position our imaging. So we commonly are positioning our functional imaging at C5, C6. So we start at C2, we identify it, count down to the C5, C6 disc, and that's where we position it. Similar, if we're doing lumbar imaging, we'll typically can see the sacrum, and we can count up from there and be able to understand where we are. Now, that said, there's a lot of variability across people, and there's sacralization, lumbarization, And you could have multiple vertebrae, but we do our best in those cases. Spinal ligaments. Briefly, going to talk about this. These provide passive sort of stiffness to the spine and can impede motion. You have an anterior longitudinal ligament, posterior longitudinal ligament, a supraspinous ligament. Those are your long ligaments of the spine. You have some short ligaments. Here, one of them is the ligamentum flavum. This one's really stretchy and flexible, and so it can help. They all kind of help restrict motion along any plane. In addition, there's some short ligaments. You've got intertransverse process. I don't remember for sure. Intertransversary. I don't know. There's ligaments there. There's also between the spinous processes. There's also ligaments between those as well. And then a very important one is the intervertebral disc, which is a ligamentous structure. It's made of collagen. And here's the intervertebral disc. So they sit between each vertebrae, and people say they do cushion and stuff like that, but they allow a lot of movement in multiple different directions, multiple different planes. And when you stack these up across multiple different segments, now you can move the spine kind of all over. And there's an outer layer called the annulus fibrosus, and an inside gelatin layer called the nucleus pulposus. I'm not going to go into detail on muscle, but understand there's muscles surrounding all these structures. They provide a lot of stiffness. Your ligaments alone don't provide enough stiffness. I'm able to stand here because I have muscles in my back that are firing right now, providing me with posture. And they're on the posterior side. They're also on the anterior side, and they're in the images as well. Cross-sectional spine anatomy. So here's just the spinal cord with its rootlets, the spinal nerve. This is dorsal root ganglion. We've got a vertebral artery here, which is in the vertebral foramen. But there's a lot more than just that. And there's a lot of structure. This space is not open. It's packed full of stuff. And so you have, not shown here, at least shown dark, there's cerebral spinal fluid in the subarachnoid space. You have epidural fat that's outside of the dura mater. There's also venous structures here as well. This was the cauda equina, which I mentioned, means, I think, horse tail. And it is since the spinal cord stops at T12L1, the nerve roots that come down to innervate your pelvis and lower limb, they come down as nerve roots. And there's probably a good developmental reason for this, but I'm not an expert in developmental anatomy. But this is how what the structures are. And then the meninges. So similar to in the brain, you have similar meninges in the spinal cord. You've got your pia mater that's outside the spinal cord. You've got your subarachnoid or arachnoid mater, and then the dura mater. And the dura mater ends somewhere where the spinal nerve root comes out, and then I think there's like a perineurum or something like that that covers those spinal the nerve roots and peripheral nerves as they're exiting. Arterial supply. So one, damage to the arterial supply can lead to spinal cord injury, but it's also important for functional MRI since we are using a blood oxygenation level dependent contrast to be able to localize signal within the cord. But you have a single anterior spinal artery. There's two posterior spinal arteries. Those could be injured and they give specific sort of patterns of injury. Venous drainage, which is more important for us. There's one posterior spinal vein, two posterior lateral spinal veins, and an anterior spinal vein here. And I think one of the important things here is that the spinal cord drains radially. So if we're trying to localize functional activity with functional MRI, I think there should be some appreciation that that's going to drain outward. So if we're trying to look at something in the middle of the cord or in a real specific location, we should appreciate that it might be towards the outside a little bit more. And similar things have been done. Similar examples exist in the brain. So I'm almost finishing up. So I talked about the bones. I talked about the ligaments. I talked about the intervertebral discs. All of these structures, as you age, they go through wear and tear, and they can break down and change. And this is spinal degeneration. So just the same processes that happen in hip joints and knee joints, those are also happening in the spine. And here's an example of some osteophyte formation, where you can see, this stuff is no longer smooth, and these structures and these changes to these structures can affect the nervous system, and lead to all sorts of different sort of deficits in sensory and motor processing. So one of these is disc degeneration, and this is an example, I guess, where these changes happen at an individual's level can lead to different sort of symptom presentations. And so example here, this is a disc herniation. For some reason, the annulus has torn, and the nucleus pulposus is able to come out into the spinal canal. And so this is the center part of me. I didn't mention it, but this is called your spinal canal, or your central canal of the spinal cord. And here it is. If it comes out here, this is the cauda equina. So it could be pushing in and causing compression of those nerve roots. The nucleus pulposus itself is inflammatory, and so your body reacts to it and can cause inflammation in those areas. Not shown here is that there's a whole vascular network as well, which also can be compressed and influence the clinical presentation of the patient. Now, it doesn't just have to come out in the center. It can also come out over here. And so this is more of a lateral disc herniation, and it's pushing down on the spinal nerve root. And here you probably would have more localized changes in sensory and motor function. Sorry, I'm pointing to my arm. This is lumbar spine, somewhere in the leg there. And maybe it'd be more lateral that you'd see. Here, the presentation could be more bilateral. One of the challenges, though, is that people most often have multi-level degenerative changes. You may have that person who has sort of a really classic, like C7 radiculopathy, and there's an obvious disc herniation. But most people show multi-level degeneration, and sometimes it can be very hard to pinpoint exactly which or what nerve root level, or what combination of nerve root levels, or where in the spinal cord is causing the condition. And a lot of times you can get like spinal cord compression itself doesn't present on its own. It's usually myeloradiculopathy. So you've got a little bit of evidence of spinal cord compression, and then also have evidence of radiculopathy. But here's an example on MRI. Let's look here. Find the sacrum. That's what I do, besides that there's labels here, which is helpful. Find the sacrum, and then you count up L5, L4, L3, L2. And you can see here at this disc between L4, L5, there's a disc herniation. There's a few different ways you could name discs. I prefer to say the disc between L4 and L5, because I think that's the easiest way to name that. It's very, very specific. But you can see this herniation. It's pushing into into the CSF. It's likely encroaching on some nerve root. You could look at this, though. This could be somebody who that comes in as a healthy control for us. And this could be what we see on their image. So it's hard to know, what's the presentation of this patient. So I mentioned, radiculopathy. Radic means root. So radishes are root vegetables. Radiculopathy is root pathology. So your nerve roots are coming off here. So any sort of compression to them, irritation to them can be considered, can irritate them and give rise to different conditions. It's a little complicated what's radiculopathy, what's not radiculopathy, but irritation to the damage to the nerve root can lead to radiculopathy. You may get dermatomal sensory deficits, also associated muscle weakness in the spinal cord segment. Also, compression of the cord here, you can see. And this can also give similar weakness, sensory deficits in the upper limb. In the cervical spine, if you get compression of of the spinal cord. You may also start to have lower limb weakness because those tracts that are innervating your lower limb are also being compressed, being irritated, and then even bowel and bladder issues as well. But then again, a lot of the times, myelopathy and radiculopathy presented a lot together, and it's also a multi-level. And in addition to that, there's also, it's not just the discs or the bone, but also these ligaments that surround the spine as well. So here's examples of hypertrophy of the posterior longitudinal ligament, as well as ossification and hypertrophy of the ligamentum flavum. And so these are those ligaments that are also on the posterior aspect of the vertebral body or the anterior aspect of the lamina. And they can get larger, and then they can encroach as well. So a lot of different structures in here can lead to multiple conditions affecting upper and limb motor function. And thank you. And then we have a few minutes. We can have a discussion. If you have any questions, I can try to answer them.
For people online?
Oh yes, if you're online, you can put a question into the chat.
Yes, question and answer, not the chat function. Yeah.
Oh, okay, correction. The question and answer function.
Yes.
Julian.
Yeah, thanks for the talk. So I was curious for the like code-based compression. What is the actual pathophysiological process that makes the ligament compress? Are they swallowing, or what's happening there?
Yeah, so it can just cause compression on its own. So they get larger. The canal is only so big, and so that can lead to compression.
And why do they get larger?
Just from degenerative changes. I don't know exactly the pathophysiological mechanism. There's also like sometimes buckling of the ligamentum flavum, where it can, I don't know, it gets pushed out. It gets pushed into the canal. It would be good, so we could save that for the panel discussion later today. So Hugo Decker's a neuroradiologist here at Stanford, and he'll be here. I will bring that up. All right. Any questions from the audience? And or yes, any questions from online? No. Okay. Let's take these minutes to drink lots of coffee and eat all the pastries, and then we'll start our next talk at 10 a.m. All right. Thank you.